Welcome to Dr. Balga's podcast for the Curious Doc. Today is January 31st, 2026. This video is on a JAMA review titled Restless Legs Syndrome, published 10 days ago on January 21st, 2026 online. What is Restless Legs Syndrome, or RLS? A neurologic sleep-related movement disorder characterized by an urge to move legs with uncomfortable sensations. How prevalent is clinically significant RLS? Approximately 3% adults experience moderate to severe symptoms. What sensations do patients describe? Creeping, crawling, tingling, aching, burning, or electric sensations. When are symptoms most prominent? In the evening or at night. What reliably relieves symptoms? Movements such as walking or stretching. Is RLS a clinical diagnosis? Yes. Diagnosis based on history. Polysomnography is not recommended. What are essential diagnostic criteria? The urge to move, worse at rest, relieved by movement, and evening predominance. Can an RLS occur without pain? Yes. The urge to move may occur without pain. Can the arms be involved? Yes, particularly in severe or long-standing disease. Why is RLS often underdiagnosed? The symptoms are non-specific and often misattributed to insomnia or anxiety. What's the role of iron in RLS? Low brain iron levels contribute to abnormal dopaminergic signaling. Is there a genetic component to RLS? Yes. Heritability may be as high as 70%. Which genes are strongly associated? MEIS1 and BTBD9, among others. Which neurotransmitter systems are involved? Dopaminergic, glutamatergic, and endogenous opioid pathways. Why do symptoms worsen at night? Circadian variation in dopaminergic activity. Which conditions commonly coexist in RLS? Iron deficiency, pregnancy, kidney disease, neuropathy, Parkinson's disease. Is RLS associated with depression? Yes. Depression and anxiety are common comorbidities. Is cardiovascular disease more prevalent? Observational studies suggest increased cardiovascular disease prevalence. What are periodic limb movements of sleep, or PLMS? The repetitive involuntary limb movements during sleep. Do PLMS establish the diagnosis of RLS? No. PLMS are neither necessary or not sufficient for diagnosis. What lab tests should be obtained? Serum ferritin and transferrin saturation. When is iron supplementation recommended? A ferritin equal to or less than 100 nanograms per ml, or transferrin saturation less than 20%. When should IV iron be preferred? Ferritin between 75 to 100 nanograms per ml, or intolerance to oral iron. How long does iron therapy take to work? Clinical benefit may take 1 to 3 months. When should iron not be administered? When ferritin is greater than 300 nanograms per ml due to the risk of iron overload. What medications exacerbate RLS? Antihistamines, serotonergic antidepressants, and dopamine antagonists. What is the first-line pharmacologic therapy? Gabapentinoids such as gabapentin or pregabalin. How effective are gabapentinoids? Approximately 70% of the patients experience major improvement. What adverse effects may limit use? Somnolence, dizziness, gait instability, and weight gain. What comorbidities may improve concurrently? Insomnia, anxiety, and neuropathic pain. Why are dopamine agonists no longer first line? The risk of augmentation with chronic daily use. What is augmentation? Early onset and worsening of RLS symptoms over time. What is the annual risk of augmentation? Approximately 7 to 10% per year. What impulse control disorders may occur? gambling, compulsive spending, and hypersexuality. When might dopamine agonists still be appropriate? Intermittent or refractory symptoms with careful monitoring. What defines refractory RLS? Failure or intolerance of first-line therapies. What opioid therapies are used? Low-dose methadone, buprenorphine, or oxycodone. Is the addiction risk substantial? Low, with careful patient selection and monitoring. What non-pharmacologic strategies are helpful? Exercise, stretching, sleep, hygiene, and limiting alcohol. What device-based therapy exists? Peritoneal nerve stimulation for refractory cases. What's the long-term prognosis of restless leg syndrome? Typically chronic with fluctuating severity. Does RLS worsen with age? Often, though spontaneous remissions can occur. Is mortality increase in RLS? Some cohorts demonstrate higher mortality and cardiovascular disease risk. Does treatment reduce cardiovascular disease risk? Observational data suggests reduced incident cardiovascular disease. Key management takeaway: correct iron deficiency and use Gabapentinoids as first-line therapy. Read the JAMA article for more details. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.